Okay, let's get this going. Good morning. I call this hearing to order. Not sure whether a quorum is present, but it doesn't matter.
It is present.
A quorum, so I'm informed that a quorum is present. Pursuant to Committee Rule 4 and House Rule 11, Clause 2, the chair may postpone further proceedings today, and without objection, the chair is authorized to declare a recess at any time. This committee's top priority is addressing the public health crisis of veteran suicide. And this is why the first full committee hearing of 2020 will explore VHA's adherence to policies on suicide prevention, care coordination, and medical facility safety and environment of care. We will also examine training for VA employees to identify veterans at risk of suicide and VA Police's role in identifying veterans in crisis on VA campuses. Today's hearing is a crucial step toward a truly comprehensive approach to reducing veteran suicide by focusing on the ways VA can provide a safe, functional, and effective environment for veterans in crisis. Suicide remains a national crisis. More than 39,000 people died by suicide in 2017 in the United States. And of these, 6,139 were veterans of the United States Armed Forces. As Ranking Member Rowe astutely noted in a recent interview, almost as many veterans die by suicide each day in this country than died in combat casualties or accidents in Afghanistan over the course of last year. VA estimates that 20 veterans and service members die by suicide each day. This is simply not acceptable. VA data indicates that of these 20 veterans and service members, 20 had received care in the past 2 years from a VA, 6 had received care in the past 2 years from a VA healthcare provider. So our focus is not only on medical staff directly treating veterans in crisis. We need to examine and improve how VA as a whole is working to create comprehensive approaches to reduce risk and prevent suicides among veterans in its care. Thousands of employees across VA work hard every day to provide high-quality, life-saving mental health care to veterans and to help them access additional supportive services. VHA is a leader in suicide prevention, research, and evaluation, and many of VHA's discoveries have informed better screening, assessment, treatment, and management for mental health and suicide prevention for all Americans. VHA has also established many policies and training requirements for facility-level leaders, mental health providers, suicide prevention coordinators, and other staff. These efforts are commendable, and credit must be given to VA for its work. Yet, since the beginning of 2018, the VA Inspector General has published at least a dozen reports on facility security, environment of care, and investigations into a lack of care coordination at VA facilities. According to today's testimony, quote, the Office of Inspector General found inadequate coordination of care to be an underlying theme in every one of its recently conducted reviews, end quote. Whether it was within a mental health treatment team, with non-mental health providers during the discharge process, or by care providers with patients or their family, there was an issue with care coordination. In 2 tragic instances in the Minneapolis VA Medical Center, emergency department staff failed to report one patient's suicidal ideation to the facility's suicide prevention coordinator. In a different case at this very same facility, the OIG determined that VA's inpatient treatment team failed to coordinate with the patient's outpatient treatment team. Both of these incidents showcase a failure in care coordination that could have prevented these veterans from completing suicide. The rate of suicide among veterans in VA's care has been steadily increasing over the past decade despite significant investments by VA toward better suicide care. VA spent $64.7 billion on mental health services in the last decade, including almost $9 billion just last year. But we have not moved the needle to stem the tide, to stem the rate of suicide. We cannot tolerate any number of veteran suicides, let alone 20 a day. VHA's research discoveries and its policies must be put into practice in every VA facility for these policies and treatment protocols to be effective. I call to mind, I'll depart from the script just slightly, but if we think about the accident rate in aviation and commercial airlines, it's pretty good. This is what I think I want this committee in this hearing today to drive at. The Centers for Disease Control and Prevention and VA have both promoted the use of an evidence-based public health approach. It requires VA to define the problem, identify risk and protective factors, and develop and test prevention strategies. When those strategies are found to be effective, VA must ensure that they're widely and systematically adopted. For this public health approach to work, VA must ensure its hospitals and clinics adhere to uniform environment of care standards. It must prioritize resources for suicide prevention coordinators at VA hospitals and clinics to coordinate care for veterans in crisis. And all, I underscore all VA clinicians, along with every other VA employee in every VA facility, must have the training to identify veterans in crisis and be empowered to act to save veterans' lives. VA already has dedicated and hardworking staff who believe in the organization's mission. By incentivizing staff to speak up, we can help VA move toward a culture of continuous quality improvement that works to reduce veteran suicide. As the Office of Inspector General noted at the West Palm Beach VA, the patient safety manager did the right thing and reported concerns to leadership about hazards in the inpatient mental health unit that represented, quote, an immediate threat to life, end quote. But the employee's concerns were dismissed, and eventually a veteran died. No employee should be discouraged from reporting serious concerns about facility safety. And when employees raise concerns, VA leaders need to take them seriously. In another example, at the Chillicothe VA Medical Center in Ohio, a veteran who was supposed to be at arm's reach from a facility observer at all times escaped view and jumped from a window. The OIG determined VA staff did not adhere to the facility's observer policy, and the facility leadership failed to monitor staff compliance. The right policy was in place, but the policy was not followed. My hope is that today's hearing will expose what must be done to ensure uniform adherence to policies, treatment protocols, and care coordination at VA hospitals and clinics, and how Congress can work with VHA to enforce these standards. This isn't about holding one single individual accountable. Instead, our approach must be to understand why policies are not being followed, whether training is adequate and utilized correctly, and how we can mitigate hazards that represent a threat to patients in crisis at VA. This crisis is not new, but our solutions and our behavior must be. I now recognize the ranking member, Dr. Rowe, for 5 minutes for any opening remarks that he may have. Dr. Rowe?
Thank you, Mr. Chairman. During today's hearings, we will assess how the Department of Veterans Affairs coordinates care for at-risk veterans, examining incidences of suicide in VA medical facilities, including 2 inpatient suicides at the VA medical facilities in West Palm Beach, Florida, as the Chairman mentioned, and Minneapolis, Minnesota, that were subject to recent reports by the VA Inspector General. My prayers are with those of loved ones of the 2 veterans and with the loved ones of each of the 20 of their brothers and sisters in arms who die by suicide every day in this country. Every time a life is lost to suicide, it is a tragedy. When suicide occurs in a hospital, a place where the most vulnerable go for help, that loss feels particularly acute. VA is a leader in suicide prevention in many respects, but if the policies and procedures that VA has in place to screen veterans for suicide tendencies and ensure their safety while they are receiving VA care is not consistently applied, the consequences can be deadly. Led by Secretary Wilkie, the Trump administration has made suicide prevention VA's top clinical priority and call for a broad-based public health approach in recognition of the fact that suicide is not solely a mental health problem, and that preventing it will require addressing the numerous health and economic, relational, and other complex factors that cause an individual to consider ending their life. And Mr. Chairman, as you were speaking, something occurred to me. We're involved in policies and procedures are important in preventing, but we need to move a step back before we get to that and prevent it before we ever get to those. If you can see what I mean, we're actually at the point where we should be preventing a person ever being in the hospital. Mm-hmm. And I think that's one of the things we need to work on, and that's the rationale behind President Trump's executive order that created the Prevents Task Force on March 5th, 2019. I welcome Dr. Van Dalen, the Prevents Task Force Executive Director, to my district last month, which we had 6 roundtables in a veterans town hall while she was in Johnson City, and discussed the various issues that are involved that I just mentioned. And the other task force members are doing to break down barriers that prevent at-risk individuals from getting the help they need and disseminate best practices for suicide prevention across all levels of government and the private sector. Chairman Takano announced earlier this week that the committee will be adopting President Trump and Secretary Wilkie's model by tackling the veteran suicide crisis from a holistic perspective and aligning our various lanes of effort under a single umbrella goal: preventing veteran suicide. We have no more important mission, and I certainly support that effort. I also want to note, Mr. Chairman, as we sit here today, the Senate Veterans Affairs Committee is meeting to mark up companion to the IMPROVE Act, General Bergman and Congresswoman Houlihan's suicide prevention bill that we spent so much time on last fall. Today's hearing will painfully illustrate once again just why the IMPROVE Act is so necessary and why it must include an ability for suicidal veterans to receive some level of clinical care from VA's partners in the community. Because of a veteran in crisis, every door should be open to having them get help that they need. Finally, as we discuss the failures and missed opportunities in West Palm Beach and Minneapolis and other locations detailed in the IG's testimony this morning, I don't want to underestimate how difficult this work is. Suicide is endlessly complex, and hindsight is always 20/20. I'm grateful to the thousands of VA staff around the country who do their best every day to serve the veterans who are struggling the most. Their work is unquestionably life-saving. I thank them for doing it and encourage them to stay the course and keep fighting the good fight just as their patients did in uniform. With that, Mr. Chairman, I yield back.
Thank you, Dr. Rowe. This morning, we'll move on to, we'll hear from Dr. Renee Oshinsky, Deputy Undersecretary for Health Operations and Management at VA. Welcome, Dr. Oshinsky. She's accompanied by Dr. David Carroll, Executive Director of the Office of Mental Health and Suicide Prevention. Good to see you, Dr. Carroll. And Mr. Frederick Jackson, Senior Executive Director of the Office of Security and Law Enforcement. Welcome, Mr. Jackson. We also have Julie Kraviak, Deputy Assistant Inspector General for Healthcare Inspections, who offer insights about gaps and barriers that are plaguing VA's ability to properly coordinate care for at-risk veterans and abate hazards that represent a threat to suicidal patients on VA campuses. And finally, we're also joined by Dr. C. Edward Coffey, Affiliate Professor of Psychiatry and Behavioral Sciences at Medical University of South Carolina. He is a leading expert on achieving system-wide culture change within a health system in order to reduce suicide deaths. So we'll begin with Ms. Oshinsky. You're recognized for 5 minutes for your opening statement.
Thank you. Good morning, Chairman Takano, Ranking Member Rowe, and members of the committee. Thank you for the opportunity to come today to discuss the Department of Veterans Affairs policies and procedures related to suicide risk and the environment in which we care for those veterans experiencing a mental health crisis. I am accompanied today by Dr. David Carroll and Mr. Frederick Jackson. Suicide's a complex issue with no single cause. It is a national public health issue that affects people from all walks of life. The CDC tells us that deaths by suicide have risen 30% across the nation. VA has embarked on a journey to become a high-reliability organization, an HRO, to eliminate risk to veterans who receive care at the VA. This journey is a long-term commitment to our veterans and to our workforce to continuously improve and drive to zero harm across VHA, drawing on lessons learned from other industries, other health systems, and leading VHA facilities. Learning from Dr. Coffey's work, we translate zero harm to zero suicides. We have begun a multi-pronged strategy that places veterans at the center of care, from the VA as well as from state and local governments through our governor's and mayor's challenges. Our suicide risk identification strategy is the most extensive standardized suicide risk screening and assessment process in any industry, but we are continuing to research and refine to make our tools even better. While we are strengthening our community network and proactively engaging veterans before crisis, it is imperative that we equip staff with the training and tools to intervene when veterans present in a mental health crisis. We have a network of over 400 suicide prevention coordinators. They facilitate the implementation of these strategies within their specific catchment areas. Unfortunately, there are times when our engagement and care coordination is not enough. In those cases, we conduct robust reviews of each case with the goal of learning ways to improve our care as we strive to become that high-reliability organization that our veterans deserve. An HRO promotes a just culture. We do not blame individuals. We generally have to focus on ways that we improve the systems that support those individuals. One key area has been the review of our physical infrastructure and environmental safety, with the focus on reducing hazards that are normally associated with suicides. In conjunction with our National Center for Patient Safety, we developed the Mental Health Environment of Care Checklist. This tool is used by interdisciplinary safety inspection teams to assess the environment for hazards and determine actions that need to be taken to protect our veterans. The rate of suicide prior to the implementation of the checklist was 4.2 deaths per 100,000 admissions. It is now at less than 1 per 100,000 admissions. VHA has recently mandated that all medical centers with an acute mental health unit install over-door alarms. All facilities are expected to be compliant by the summer of 2020. However, most medical centers have already finished the installation. This is an example of high reliability. When deficiencies are found, VHA has the opportunity to scale innovative solutions across the enterprise. Our emergency departments are another high-risk area. All patients are screened during the visit for suicide and homicide risk. The ED directive is being revised to ensure that all EDs have at least one psychiatric intervention room. We are working towards standardizing our clinical processes in these EDs. Many sites have made permanent police officers stationed in emergency departments. Others patrol them as needed. We work with our police force to heighten awareness to improve surveillance of parking lots and parking structures. We are installing deterrent devices that inhibit self-inflicted harm on exposed roofs of parking garages. With increased rounding, we can reduce opportunities for suicides when VA police are alerted and can take actions to stop veterans and keep them safe from harm. Recently in Cincinnati, a VA police officer working a parking detail observed a female veteran attempting self-harm on the 6th floor of the garage. After attempts to verbally de-escalate the situation, 2 officers and an employee pulled her to safety. Collaboration between law enforcement and healthcare professionals is crucial when responding to veterans at risk. Our police officers have over 30 hours of classroom training specific to de-escalation and conflict management and continue to focus on suicide awareness and prevention. Over the course of 2019, VA police have intervened to stop veteran self-harm in many instances, including in Loma Linda, Murfreesboro, Detroit, and Syracuse. All of us are saddened when any person attempts to take their life. We appreciate this committee's continued support and encouragement as we identify challenges, solutions, and opportunities to apply evidence-based practices that result in the reduction of deaths by suicide of our nation's veterans. Thank you for the opportunity today. This concludes my testimony.
Yes. Next is Dr. Julie Kroviak. You're recognized for 5 minutes for your opening statement.
Thank you. Chairman Takano, Dr. Rowe, and members of the committee. Thank you for the opportunity to testify today on a topic that not only impacts veterans and their families, but the entire country, ensuring our nation's veterans receive timely access to the highest quality of mental health care in a setting that is comfortable, safe, and respectful of their privacy and unique experiences. Prior to joining the OIG in 2014, I had the honor of serving veterans as their primary care physician for over a decade at VA. Treating veterans with complex mental health care needs not only requires sophisticated clinical skills, but also training and compliance with policies and procedures to guide seamless coordination of care. I witnessed inspirational recoveries and successful reintegration into civilian life. But I, like other healthcare providers, also experienced grief and loss when a patient died by suicide, despite receiving quality mental health care. The OIG shares this committee and VA's priority to improve VHA's mental health and suicide prevention capabilities. We recognize the significant work VA's dedicated mental health providers and other professionals are doing. However, there are still considerable challenges. VHA's effort in suicide prevention, including the Veterans Crisis Line, have been largely directed at crisis intervention. But the opportunity to intervene once a person decides on self-harm is very short, often less than an hour before the actual attempt. For veterans, it's even more fraught with peril because they are very likely to use firearms. To significantly reduce suicide and improve veterans' lives, prompt and effective mental health treatment must be paired with a wide variety of additional approaches. For example, VA has promoted firearm safety by urging veterans to secure guns with locks, remove firing pins, and store firearms where they are not easily accessed. My written statement discusses numerous reports the OIG published in recent years detailing veterans' challenges in accessing and receiving high-quality mental health care within VHA. Tragic events such as suicides are the most publicized and are typically understood to be the result of unrecognized, untreated, or undertreated mental health disorders. Because of this, much of our work focuses on the complete healthcare journey of those veterans with a wide variety of mental health diagnoses and treatment needs. Our reports identified deficiencies in how VHA staff coordinated care for veterans in mental health crisis, as well as the quality of the environment where veterans receive that care. On the first point, we found breakdowns in communication between members of the mental health treatment team. We also found communication failures between mental health and other clinical providers, community resource contacts, families, and caregivers. Such gaps in communication and care coordination weaken effective management and discharge planning and ultimately put patients at risk for serious complications and potentially devastating outcomes. While policies promoting effective communication may have been in place, staffing shortages, inconsistent training, and leadership failures compromised patient management. We also found risks in the environment where veterans received their care and made many recommendations to VHA aimed at ensuring a safer therapeutic setting by correcting structural and other hazards that are unique to high-risk patient care. The recommendations also support staff and visitor safety. We take a proactive approach to evaluating the environment of care and continuously review site-specific allegations related to cleanliness, safety, and facility maintenance. This supports VHA's work to maintain a clean and safe, healing, recovery-oriented environment, and is even more important in areas often associated with higher risks of harm to patients, such as locked mental health units. Despite VA's efforts, there are significant challenges ahead. VHA must continue to focus attention on outreach efforts, providing all stakeholders with evidence-based tools that not only help identify high-risk veterans, but also encourage those veterans to engage in the care they need. Mr. Chairman, this concludes my statement. I would be happy to answer any questions you or other members of the committee may have.
Thank you. Dr. Coffey, you are recognized for 5 minutes for your opening statement.
Good morning, Chairman Takano, Dr. Rowe, and members of the committee. Thank you for inviting me here today to participate in this very important conversation about the public health crisis of suicide in our country. You requested that I share with you our experiences at a non-VA health system in implementing a comprehensive suicide prevention strategy. And in my written comments submitted earlier, I described the work that we began at Henry Ford Health System about 20 years ago, known as Perfect Depression Care. In my comments this morning, I'd like to briefly describe that model and then dive into a bit of the detail around zero suicide and how it might apply as a model for other health systems. So our adventure began back in 2001 when the Institute of Medicine published its groundbreaking report, Crossing the Quality Chasm. You'll recall that that report called for a sweeping overhaul of America's healthcare system. It was described as badly broken and not repairable. It had to be overhauled and transformed. And the report also provided a model for how we might move forward to create that transformation. Now, in response to the report, the Robert Wood Johnson Foundation and the Institute for Healthcare Improvement launched a national collaborative called Pursuing Perfection. And the goal of that collaborative was to incentivize and support healthcare systems to use the CHASM report as a roadmap to rapid transformation and dramatically better care, indeed, ideal care. And I emphasize the word ideal here because they weren't looking for better care. That's not going to do it. And they weren't even looking for best care. What's it mean to be the best in a mediocre industry? They were calling for ideal care. So that was the challenge from the collaborative. At Henry Ford, we chose to focus our participation in this collaborative on our depression care system. But we struggled initially to create a vision for what perfect depression care might look like. How would we know if the care was perfect? And more importantly, how would our patients know if our depression care was perfect? And we struggled with this issue for many, many weeks. We had focus groups involving our patients, their families, community leaders, our system healthcare leaders. And finally, one day, one of our staff spoke up and said, well, maybe if we were doing perfect depression care, nobody would die from suicide. And our room was as quiet as you are now, but that moment transformed our department, absolutely transformed our department. We began a conversation wherein we recognized that this goal might sound unrealistic, might sound impossible, might be frustrating, might create problems in some scenarios, but we decided that if 0 wasn't the right number for our goal, what number could be the right number? And so we began an initiative to transform our mental health care delivery system, and to make a long story short, we achieved a dramatic and unprecedented reduction in suicide among our patients, a 75% reduction that was sustained for a decade in Detroit. And this was occurring at a time when the rate of suicide in the state of Michigan was actually increasing, just as it was in the rest of the country. So this concept of zero suicide has been endorsed now by the Joint Commission, the CDC. It's embedded in the 2012 National Strategy, as you probably know. And a number of organizations and governments across the world now are adopting at least iterations of this model to try and get a handle on this issue of suicide. So just now a word about the model, and it's described, or depicted at least, in this graphic that's being shown, and you have a copy of it in the written report. There are 3 components to this model. And starting at the base of the pyramid, that first component is a radical conviction that ideal care is possible. Now, this sounds sort of common sense, but believe it or not, there is not a universal belief, at least in mental health care, that we can prevent all suicides. That belief doesn't exist. And so maybe we need to look at that and challenge that issue. If we don't have that conviction, we don't have the energy needed to do the relentless work of transformation that's so hard and that requires attention each and every day. The second element of this model is a roadmap, which we call pursuing perfection in a just culture. So the goal here is to set perfection goals, not incremental goals, which we typically have done forever in healthcare. So for example, if your suicide rate is, I'm making up a number, 10, and your goal is 0, you commit to cutting that gap in half in some period of time. In our case, it was 12 months. 0 is the goal. Where are we today? We're going to cut that in half over the next period of time, and that gap we'll then tackle in the next 12 months to cut in half. That's the concept of pursuing perfection. Now, this is not possible, as Ms. Oshinsky mentioned, if you don't have a just culture. If you expect people to go up to the plate and swing for the fence every time, and then turn around when they strike out and punish them, it's not going to happen. It's not going to happen. So we have to transform our systems to look at where the defect occurred at the system level, not at the person level. We went so far, for example, as to take the word who out of our process maps for error reviews. We removed the word who from the document. And then lastly, every member of the team needs to be an expert in systems engineering. That's really healthcare today. Healthcare is a team sport where we work together to create systems that reliably produce the best quality care, indeed perfect care. So I think the model, while initially sounding audacious, has application to a number of healthcare systems, and I think it's worthy of further consideration and research. Fortunately, research is underway now, sponsored by both NIH and Samsa, to look at the essential elements of this model and how we might make it even more effective. So thank you again for the opportunity to be here today, and I'm looking forward to our comments.
Thank you, Doctor. I will now recognize myself for 5 minutes for questions. So after the release of the VA's OIG report on the veteran suicide at the VA Medical Center in West Palm Beach, I called for a VHA-wide stand-down last September. This was to ensure facilities were adhering to their policies and so that employees were trained to confidently assist veterans in crisis and raise concerns with facility leadership and have those concerns taken seriously. In West Palm Beach, we learned that cameras were not functioning and the patient safety coordinator's concerns about facility safety were not taken seriously by facility leadership. Ms. Oshinsky, are the security cameras functioning in the inpatient unit at West Palm Beach?
Thank you, Chairman. Yes, I confirmed that the cameras are working both in the acute mental health unit as well as in the emergency department.
How about the door alarms?
Yes.
Thank you. You said in your oral testimony that door alarms will be installed in all VHA facilities by summer of 2020. But the VA's written testimony says May of 2020, March. When will door alarms be installed in every VA facility? Can you clear up that discrepancy?
Thank you for the opportunity to clear that up. One of the things that we've done as we are installing this across the enterprise, what we have found is that we no longer are able to get the appropriate equipment. We've the market doesn't have the supply that we need in order to retrofit all our facilities. So for example, places that I saw an issue brief just the other day that talked about we were supposed to be done, the delivery cannot be made, so instead of being done in March, it has to be done in May. So we are working very hard to get this done and hoping, and again, I do have to say, probably hoping we are done by summer, but it really is dependent on the ability to get the appropriate equipment.
And again, the door alarms are part of the standards, VA's own standards. Is that correct?
That is correct. We put this on ourselves because we believe it fits in exactly with what we're talking about, zero suicide and zero harm. If you go out to the community, you are not going to find as many, when we have to send people out, many of those places will not have over-door alarms, but we want to be the standard.
So this is an example of you know what to do, but we know that knowing it is not the same as being or doing it. So it is concerning to me that that there seems to be so many facilities that are without door alarm. How many facilities across out of your 150 some odd facilities need door alarms?
Every facility with an acute mental health unit, I'm not sure if Dr. Carroll knows how many of those there are. And we probably have completed, I believe, 80% of those now. If I could share just a story
Sure.
of something that came in on Friday, is that there was an incident at Loma Linda where a resident.
Excuse me,
Okay.
I said yes to the story, but I've got limited time, and I've got to get to a question to Dr. Kroviak. Dr. Kroviak, why do facilities continue to struggle with adherence to environment of care and care coordination policies?
Thank you. So, as you've described in your opening comments, the policies are in place, but the actual work that needs to get done consistently on the front line is where the problem usually exists, and that's where what our reports highlight. Most of the reasons stem from staffing shortages, inconsistent training, and ultimately leadership failures at the local level to ensure that the policies are consistently played out.
So staffing shortages, leadership failure, and inconsistent training. Ms. Oshinsky, why aren't facilities following policies, your own policies?
I think there's an effort on the part of individuals to follow policies. As we talk about filling vacancies, oftentimes new people will come in. We need to ensure that we train them at that time and that we continue to retrain. I really believe that is a large part of the issue.
Well, the GAO placed VHA on its high-risk list in part due to this problem. So this has got to be a bigger priority. We must ensure that the 6 veterans out of the 20 veterans who commit suicide a day, who commit them at VA facilities or who are connected somehow in the VA's care, you know, I agree with Dr. Rowe. We need to address the upstream interventions, but we definitely need to make sure that the public is assured that the VA is a safe place for a veteran who needs critical emergent care to go, and know that the standards everywhere are at the ideal level. Dr. Rowe, you're recognized for 5 minutes.
Thank you, Mr. Chairman. On the mandatory suicide prevention training, I said since 17, the last 3 years, all VA employees, both clinical and non-clinical, are required to undergo mandatory annual training. The newly hired clinicians must complete a web-based course entitled Suicide Risk Management Training for Clinicians. I want to take that course. If you all can get that, I want to go through it and see what I think about it after I get through. Dr. Coffey, I want to go over a couple of questions that I'd like to have for you. Do you have evidence that the suicide prevention model that your testimony focuses on has been able to achieve sustained reductions in suicide in the healthcare systems where it's being used?
Well, to state the obvious first, its implementation has not been wide at this point in time. There are a small number of organizations. Centerstone in Tennessee is one that's reporting results similar to what we saw at Henry Ford. Now, remember, ours is a quality improvement initiative. It's not a controlled experiment. So when we talk about evidence, it's a different level of evidence. We're doing lots of things at one time to try and quickly improve the systems of care. So it's very hard to say this particular intervention resulted in the particular outcome. That's the point of the research that's underway currently with NIH and Samsa. But, and then others, in addition to Centerstone, there are some tribes in the U.S. I think Samsa has testified to this committee before about some of the work that's being done there. And they're also reporting preliminary positive results.
Well, and they've heard, the members here have heard me say this many times. We have in the Guard in Tennessee, we have a program called Guard Your Buddy, which has been shown to reduce suicide by almost 70%, very similar to what you recognize. And given the opportunity that significant increases in suicide in our country among our veterans, the supposed effectiveness of the zero suicide model that your testimony references. Why is the zero suicide model not more widely known and adopted? Why is it just, and I mentioned to you before we started the committee hearing about Dr. Van Dalen, who is working with the administration through the VA, and they should be in contact with you.
Well, I don't know the answer to your question, obviously. I mean, I guess we could do a study and do a survey and find out what's going on. From where we sit, a lot of organizations are acknowledging an aspirational goal of zero suicide. And I wonder whether that sort of goal is really sufficient to generate the traction and the energy that's needed to do this kind of work. If we say, well, we'd really like to get to zero, you know, if everything works out okay, that drives one set of behaviors. If we say, nope, we're committed to a non-event, not on our watch, not today, then you have a very different set of behaviors that take place. So I do think there is power in how the goal is conceptualized and articulated.
I agree with you 100% on that. I mean, my goal when a patient came to me who was pregnant was to have a healthy baby and a healthy mother. That was my goal, every single patient I saw. I think one of the most distressing statistics I heard during our roundtable in Tennessee was that the second leading cause of death between the ages of 10 and 34 is suicide. That is an amazing thing. And we've seen the rate go up in the population in general, and I think our veterans are mirroring. I mean, we all live in the same environment. And when you peel the onion back, you find out it's relationship difficulties, it's financial difficulties, it could be substance abuse, which could be caused by those first two things I mentioned. And that's why I believe we have to really get back and reconstitute our mental health infrastructure in this country. We dismantled it in the 70s and never really put a place. If you're working in an emergency room right now, Dr. Coffey, and you know this very well, if you're down there and you see a patient, and I applaud the VA for having a place to start the treatment and a coordinator that you can hand someone off to. If you're in the civilian sector, you're an ER guy in Union City, Tennessee, I picked that out, you basically have nowhere to go. And that's a sad situation in a country as wealthy as we are and as much money as we're spending. And I think I want to give the VA a shout out. And there are some, obviously we're going over some problems today that the VA had. But all in all, I think the VA probably has the opportunity to be one of the best systems in the country. I really believe that because the resources are there. My time's expired, I yield back.
Thank you, Dr. Rowe. I thank you for mentioning the dismantling of our infrastructure, mental health infrastructure in the 1970s. I agree with you. Mr. Lamb, you're recognized for 5 minutes.
Thank you, Mr. Chairman. And I'll kind of pick up where Dr. Rowe left off. Dr. Coffey, could you spell out maybe what are the challenges you would see for a large and kind of powerful and distributed organization like VHA in adopting your model or beginning to adopt it? How would you recommend that something like that even get started if it was something they were serious about pursuing?
Yeah. Well, I think they are serious about it, and I think they are beginning to adopt, as you heard, various elements of the model. The challenge for any system really begins at the leadership level, I think. And I'm not singling out the VA here, I'm just talking in general. Right. Can leaders get behind a quantitative goal of zero defects? I mean, can a culture stand that? Can it withstand that kind of examination and public statement that we are not going to have, fill in the blank, a medication error in our organization? We're not going to have a patient fall in our hospitals. We're not going to have a pregnant woman have a problem with her delivery. Zero. So I think that's the first step.
Well, and I guess on that, when you talk about leadership in an organization as large as VA, there are so many different levels of leadership. Like, it would be one thing for the secretary to say that at a press conference. It's a whole nother thing for the person who's really in charge on the ground at an individual health center or even community outpatient center to be bought into that and supervising it, on a day-to-day level. In the military, they say inspect what you expect, right? I mean, like the person that's the leader who I'm thinking of, the on-the-ground person. So how does that change get made? How do you get that person bought in to what you're talking about?
Well, again, I think it's culture building. I always think back to the movie Apollo 13. And one of my favorite movies, but if you remember the story there where the moon landing had to be canceled and they had to get the capsule back to Earth, and there was no possible way, according to all the scientists, that this was going to happen. In fact, their power was going to be 2 days short. It's impossible. Can't happen. And every individual in NASA at every level participated in bringing that capsule back to Earth safely. And it was that participation was driven by, some of those famous quotes from the movie, Houston, what more can we do? Houston, what more can we do? That's Tom Hanks' character saying that. And of course, that on the ground, failure is not an option.
Yeah.
Failure is not an option.
You talked about department-wide certification in cognitive behavior. What would it take to achieve that in, say, an individual hospital? I guess in terms of like how much training time and resources were we talking about in your experience to achieve something like that?
Right. Well, I'll make a point first of all that, as I mentioned in my report, we ended up not getting the grant. We got a small training grant as part of our participation, but we weren't one of the 6 finalists who got $1 million to do this. But we were so geeked about the whole thing that we decided to pursue it anyway. So we had 0 budget to do this at Henry Ford. We had no resources. And so what we had to do had to be supported.
Time is your resource at that point.
It had to
right?
be
I mean,
supported by taking something from somewhere else that
Yeah.
wasn't adding value and investing that resource here where it did add value. In the case of department-wide competency in CBT, we sent key trainers to the Beck Institute, the birthplace of CBT, and got them formally certified, and then brought them back, and they became the trainers on the ground for our team locally. And there was an expectation by a certain date that every member who engaged in the provision of psychotherapy at Henry Ford was going to be certified by the Institute. That's the way we do it.
And do you have any estimate of what that means in terms of hours, days, weeks?
It's an intensive process.
Yeah.
Because the supervision is very intensive. There are audio tapes of the session. Those are sent to Philadelphia. They're critiqued,
Wow, okay.
coached. Now, the model may be a little bit different today. I don't know. But it was intensive. But most of the staff
Thank you.
enjoyed
Sorry,
it.
I hate to cut you off.
Yeah,
Just
that's
one last question before my time runs out.
Yes.
Dr. Oshinsky, I think we had a hearing last year where Dr. Franklin mentioned that there were 444 suicide prevention coordinators on board, but an additional 246 were on the way in the hiring process. Do you have any idea where we are on those numbers at this point?
I would have to take that for the record unless Dr. Carroll.
If you wouldn't mind
Yes.
just getting back to us. I think
Thank
we
you.
had 444 active and 246 on the way. If you could just give us an update. Thank you,
Yes.
Mr. Chairman. I yield back.
Mr. Bilirakis, you're recognized.
Thank you very much. Appreciate it, Mr. Chairman. Thanks for holding this hearing. Ms. Oshinsky, recently the VA committed to proactively contacting new transitional service members through the Solid Start program, and your testimony credits this directly to the President's 2018 executive order focused on mental health for transitioning service members and veterans post-separation. What type of suicide screening is being done through this program, and how does VA plan to track its success?
Thanks for the opportunity to comment. I'd actually like to ask Dr. Carroll if he would. He has much more information about the detail of that program to address the question you raised.
Okay.
Thank you, sir. We appreciate the question. Solid Start is a transformative initiative that, with your support and that of the administration, VA has undertaken. It's taken us a while to build this capability, but within the first year after separation from service, we are calling each transitioning service member at least 3 times. To the point of your question, the contacts are are checking in with the veteran. They are not clinical contacts. It's not a clinical interaction with a clinical provider screening them for suicide, but it is the caring support. It is making sure that they are connected, that they feel connected, that they know how to connect to either resources in the VA or the community. And then if they need something or they indicate, you know, if there's a crisis, we will hand off a warm handoff to the crisis line. If they need some other service from VA, there will be handoff to service. But it is really to remind veterans that they are not alone, that the VA is there for them as well as local resources.
But let me ask a question, clarification, because I know we had language in the Mission Act. Can a veteran go to a community health center, a walk-in clinic, or what have you, to seek private care for mental health counseling, what have you, and with the VA reimburse? I know there's some language there. I've had some legislation to strengthen that. Where are we on this? Because I think it's so very important. Now, if you can't answer the question now, please get back to me. You know, has this been implemented? How easy is it for a veteran, you know, for convenience purposes too, to go to their local community health center for mental health treatment?
I believe after an initial approval, it would be very easy, but I would like to confirm that for you for the record to make sure that could someone do it without authorization?
Anyone else? Okay, well, please get back to me on this because I think it's very important that the patient, again, the veteran have access to these services. One more question. I just had cataract surgery, so forgive me. It's tough. Ms. Oshinsky, what type of suicide prevention materials or training is provided to service members as part of the VA's portion of the Transition Assistance Program?
Again, I'd like to recognize Dr. Carroll as our expert on these programs.
Please, Doctor.
Thank you. So over the last couple of years, the Transition Assistance Program has been remodeled, redone in collaboration with DOD, our DOD partners. And I think there's an entire day that is focused on VA services, on VA care. There's a focus on suicide prevention, how to register for care. In fact, we actually asked them to complete an application for VA care that can be activated as soon as they are separated from service. And there's information about suicide prevention and how to reach out for resources. And what we are also trying to do is to include information for family members, so family members also have that information as well. And then these calls that you mentioned earlier, sir, will remind them of that opportunity going forward. And if I may just circle back to your last question for a moment, if any veteran ever contacts us, we're going to find help for them today. And so if they come in and whether they're registered with us or not, if someone calls us or walks into one of our medical centers, we are going to find help for them today if they need it.
Okay, that same day?
Yes.
Okay, that's so very important. Time is of the essence in a lot of cases. Ms. Oshinsky, or whoever wants to answer the question, whoever's qualified to answer the question, you mentioned, Ms. Oshinsky, you mentioned briefly in your testimony about the whole health program. As a strong advocate for this program and the use of a public health and whole health wraparound approach to suicide prevention, I want to ask what progress is VA making in implementing findings for evidence-based alternative therapies that are otherwise outside of VA's traditional mental health system. I know that my local VA hospitals do an outstanding job with the alternative therapies, but I want to see this nationwide. So can you, whoever's qualified to answer the question, I appreciate it.
I can help with that one. Thank you for the question.
Okay.
Whole health is currently being expanded across our system. While we started out with 18 flagships, each of the network has been asked to identify 2 more facilities within their network to be able to expand, but also to spread across every single facility in the country. So in the coming year, we'll be doing increasing training, but I can tell you right now, people feel exactly the way you do. They can see whether or not the evidence-based is all out there, and I understand we are probably close to being able to issue a report with research on that. I haven't seen it yet, but I understand it's in process.
Yeah,
that really
it's gotta get-
shows that this
yeah,
is
we're waiting
something
for
that
it.
makes a difference.
Yeah.
So everybody wants to do it. They're doing it whether they're identified as a flagship or not.
All right, very good. Thank you. I yield back. Thanks for giving me the extra time, Mr. Chairman.
You're
I
welcome.
appreciate it.
You're welcome,
Thank
Mr.
you.
Bilrakis. Mr. Brindisi, you're recognized.
Thank you, Mr. Chairman. Ms. Oshinsky, just in response to Congressman Lamb's question, I also would like to see the numbers on the suicide prevention coordinators, because I know in previous testimony, the former national director talked about a surge in hiring. So if you can get that to our office as well, I'd love to see those numbers.
Certainly.
And then my main concern, I represent a very rural district in upstate New York, and I know you all know the challenges of serving veterans in rural communities because of the lack of cell phone service, the lack of internet coverage, the transportation and distances to community-based outpatient clinics or hospitals. So, Ms. Oshinsky or Dr. Kroviak, can you speak to the VA's efficiency in reaching veterans who live in rural communities?
Thank you for the opportunity to address how we reach out to veterans in rural communities. And I agree, we've tried to make sure that we have community-based outpatient clinics whenever we can, and that we are expanding our telehealth network. But as you said, we also are struggle sometimes with the bandwidth that you may have in more rural communities. We are working with a variety of private sector folks as well. One of the things I'd like to highlight is we are trying to work with Walmart because there are Walmarts in very many rural communities across the country. Is there a way that we can do that? So that's one of the areas that we're looking at. Dr. Carroll, would you like to add anything in terms of other alternatives?
One of the things that we have developed recently is a program called Together with Veterans. It was developed by our team out in Colorado, and it is a evidence-based program to go into rural communities and to help those communities recognize and connect and support with their veterans in their local communities. We've seen promising results from that, and we are spreading that across our system in addition to what Ms. Oshinsky said about the importance of telehealth services.
Dr. Kroviak.
Yeah, if I could add, we are also very much aware of the challenges associated with providing care to rural veterans, in particular specialty care. So we've developed several products that are now looking, taking deep dives into specialty care coordination for rural vets, as well as the expansion and safety of telehealth.
What else can we do in Congress to help VA reach these veterans? Any ideas?
Well, certainly we appreciate the support that we have from this group and through the funding process. I mean, we have worked very hard to try to expand bandwidth. Sometimes, and as you know, it can be difficult in some of these more rural areas. So I think the awareness, one of the things I think is just so important is that really younger veterans in particular love telehealth. And I think we need to do everything we can to make sure that people understand just how effective telehealth can be. So, Dr. Carroll, anything from your standpoint? Okay.
Thank you. Okay. And then another question I have, Ms. Oshinsky, you mentioned in your testimony that suicide prevention coordinators also do outreach to Guard and Reserve units, and they come to mind as one population that could be served by VA mental health services. And I've introduced legislation, it's bipartisan, the Care for Reservists Act, that would do just that. If Congress decided to expand critical mental health services to more populations, what are the challenges you see in making that work?
It is, thank you for the opportunity to address that. I don't think it's a secret to talk about the fact that sometimes the issues of trying to recruit, particularly in areas where it may be more, where we may have smaller populations, we can struggle with recruitment. So I think that would be something that we would face. However, obviously, if the Congress wanted us to expand those services, we would do whatever we could to make sure that that occurred.
Do you think that you have the staff capacity at VA facilities to serve more veterans?
Well, I think we are we are serving as many veterans as we can. We are looking at ways that we can expand that. Dr. Carroll?
Yeah. As we continue to expand our mental health staffing, and we have increased our net mental health staffing over the last 2 years, but the demand also increases. And so I think, we are hiring to meet the demand. As demand increases, we need to continue to hire. Support for our training programs is an important component because that's a major way that we recruit providers into our system.
Okay.
Thank you for recognizing my angst and wanting to participate.
Thank you, Doctor.
I would also really stress the importance of a staffing model. It is near impossible to staff up to the demand when you haven't really measured exactly what you need and where you need to spend your dollars in that staffing.
Thank you all.
All right,
I yield back.
thank you, Mr. Medici. Mr. Bost, you are recognized.
Thank you, Mr. Chairman. Mr. Oshinsky, let me ask this. We know that, first off, that zero number that we're trying for is very difficult because so many are not even coming in contact with VA. But the fact that we have them actually committing suicide at the VA is a huge problem. What is being done, I know you explained a little bit of it, but when Dr. Coffey was giving his testimony, he said that it's the mindset of all thinking and understanding that that zero number is possible. What is it that we're doing to train our frontline staff and make sure that they have that same attitude?
Thanks for the opportunity to address this. I think there are several levels of this. First, I think the kind of training that we do, the SAVE training, making sure that people understand the very most important thing about recognizing suicide is the fact that, or preventing it, is recognizing when someone is having an issue. So it's that direct kind of interaction that each and every one of our employees, whether they be in a facilities management employee or someone who's doing grounds maintenance, those folks sometimes are the ones who first run into people outside the emergency department or on their way in and will actually bring things to others' attention. So I think we are beginning to get there, but we need to continue to do that kind of interaction. I will tell you that when a veteran commits suicide on a VA campus or harms himself on a VA campus, as a network director, I used to go in and visit the teams, the suicide prevention coordinators, and then some of the teams. The emotions that came out in those meetings, this is the most difficult thing for any provider, to lose someone, when you know that VA is there to do something good for people and instead they harm themselves. So it is something that every employee at the VA is on the alert for.
Dr. Gravek, in your testimony, you actually talked about a particular case where someone that was a high risk, the red flag was removed. What are we doing to make sure the procedure does not go down that path again?
So that was a critical recommendation in the report you're referencing. In fact, it was the first recommendation, and we follow up on the recommendations with data from VA to show that the changes have been put in place. We have not yet closed it. The data that we've been provided hasn't supported sustaining that. So until we see enough data to suggest that it's been implemented, corrected, and over a course of time, would we then close that recommendation to say it's been satisfied?
Okay. You know, and as I said off the start, the worst thing we could have is these suicides actually occurring in our facilities.
Yes.
Manpower and being informed and communication is vitally important. I know that's part of what you're working on, but you brought up a issue that also the people of maintenance is vitally important. I know when reading our report, one of the suicides was the fact that a hallway camera was out. In my particular case with one of my VAs, which actually does a great job, and that's the St. Louis VA in Johns Hopkins, we had a person that actually walked in to the waiting room at 4 o'clock in the morning, actually contacted his nephew and said what he was going to do. because he was angry about the service he received from the VA. Committed suicide, laid down on the bench, committed suicide, and it was an hour before he was found. The implementation and the putting in of those proper cameras and observant and making sure that our staff understands and also then understanding that our staff needs to be informed for that zero policy. These are things that this committee is wanting to push so hard to try to reduce this unbelievable level of suicide rates. But the zero policy for our facilities has got to be met. I think you're trying. Anything and everything that this committee can do, let us know, but we will continue to have oversight of this. Thank you for being here today, and with that, I yield back.
Thank you, Mr. Boss. I associate myself with your sentiment toward the end. I agree that we have to drive a zero policy at the facility. Ms. Luria, you're recognized for 5 minutes.
Well, thank you, and thank you all for being here today to talk about this very important issue of veteran suicide. And I associate myself with my colleagues' comments that we all focus and want to provide as much help, assistance to the VA to accomplish your mission as possible in this area. One of the things that came to my attention in the testimony that you provided ahead of today's hearing is that 99 out of 140 VHA facility directors reported that they had at least one severe shortage area in mental health care providers. So I wanted to know how that affected our community. I reached out to the director and the staff at the Hampton VA in Virginia, and I found out that the vacancy rate at the Hampton VA for mental health care providers is 35.5%, whereas the VHA rate in mental health across the country is 10% roughly. And in certain areas, there's 0 providers, so 100% vacancy in that specific field or type of provider. So that made me think, you know, are staffing shortages the reason that you're not meeting benchmarks, that you feel that you're not necessarily able to provide the care and the time to the number of people who might need the care? Just basically, what impact is this having on our ability to go after this problem?
Thank you for that question. Definitely the issue of trying to recruit the appropriate staff to staff all our mental health units across the country continues to be a challenge. As Dr. Carroll mentioned, we've made some tremendous progress in the last few years. However, there are pockets, and you are mentioning one of those, where we still have difficulty trying to bring the staff on to the level that we need to support the demand, because you have a very high growing area where we have a lot of veterans who are seeking care. So it is something that we're working on. Dr. Carroll, you may have some additional information about that specific site.
Well, and also as you continue to address this in your response, what can we do about the hiring? I understand the shortage of mental health care professionals, whether I'm at a jail, a school, the VA, anywhere in our community, there's a shortage. But why is the VA not one of their locations of choice for employment? We have both the Hampton VA and we have 2 military and treatment facility hospitals as well, one with Portsmouth Naval Hospital. We constantly losing providers between DOD, VA. It takes months to bring someone on board, even if they're identified. So just at the administrative level with the hiring process, can we not do something to make that more efficient, to make it a more attractive place to work, to be able to provide health care to these these veterans?
Before I turn it to you, Dr. Carroll, a couple things just to say. We have an initiative to hire right, hire fast. So we are really trying to do that, and we would target a particular area like Hampton because of the vacancy rate. We are also trying to use all the flexibilities that we have in terms of what are the kinds of incentives that we can offer people.
But for the hire fast, so I've been to the VA 4 times in the last year, and I hear that it takes them months. They have to re-credential someone. I mean, someone might already be working for a VA facility in another state. They might be working for DOD. They're already working as a healthcare provider in a federal healthcare system. Why do we have to go back to ground zero and verify every single credential when there should already be a standard record saying that this person, meets the standard to be employed by us? It's adding months and getting people into a treatment room where they can treat veterans who need the care. So can we do anything to streamline the process and just get rid of what seem like true redundancies?
We are taking a close look at the credentialing process and what are the things that we can do to improve that. But you're exactly right. It is challenging, and we do replicate that information. I think the issue is you never want anything to slip through the cracks. So we need to tighten up our process and make sure, just like everything else, we have 0 defects when we do this as well as anything else. Dr. Carroll, anything else?
So I would just highlight it. We have a mental health sustainability initiative going on currently where we're looking at not just bringing on new providers as we want to do, and we've had success with that, but we're also looking at retaining our providers. And so we have had a national program to conduct stay interviews because we want to minimize our losses, and generally speaking, we do fairly well in that regard. We're also looking at things like open and continuous recruitment for these critical vacancies that you mentioned.
Well, I'll just bring something up about retention. And I have found that, providers like to work at the VA. They like to provide that care. But the environment for employees at the VA right now is very tense and very stressed, especially due to the fact that a lot of them feel like they have no recourse as far as some of the executive orders that have been passed, the fact that employees are being disciplined without the ability to repeal those specific actions, the fact that unions are basically that represent them and represent their rights are being kicked out of VA facilities, that time is not allowed for the people who represent them. And I hear this over and over again from longtime VA employees who want to continue to work there, but they really feel like their rights are being infringed on. And how do you address that with your workforce to make them feel like they can have fair representation and fair recourse in employment decisions?
You may answer the question. Go ahead.
Well, I think one of the things that is very important to all of us is that people have the opportunity to be able to respond to or raise any concerns that they have. I mean, that's why we established the Office of Accountability, so that there are places for people to go. There are hotlines, anything if they are worried about things that happen. I have to say that my preference is,
When you say people, this is for employees.
staff, I'm sorry, yes, for staff. I apologize for using that terminology. For any of our employees to go. I mean, I am hopeful that our leadership is listening, and that one of the ways that we can learn to better ourselves is by listening to our employees and reacting to what they tell us to make the environment a better place. That's the expectation that I would have of anyone who works in our environment.
And within mental health, we conduct an annual mental health staff survey every year, and that is part of our metric in terms of how we look at the experience of care. It's not just from the veteran's perspective. That, of course, is the most important thing, but we need to find out from our providers, and we do, whether or not they can schedule appointments as frequently as they feel that they should, whether they feel supported by leadership. So we ask that annually, and we use that in our oversight process.
All right.
I appreciate the feedback on that. I'll just tell you from what I hear from employees at the VA in our region is they don't necessarily feel that they have that outlet. And we have new leadership. I'm very encouraged by our new director, and I know that he's working very hard to improve that morale. But just as one VA around the country, I just wanted to make you aware that there's a significant amount of concern amongst the VA employees.
Ms. Loria, we have to move on, but thank you. I associate myself with your frustration and with the hiring process and climate, but we need to move on. Ms. Rattlewagon, you're recognized. And by the way, thank you for that lovely shirt you sent me. Thank you.
Thank you, Mr. Chairman and Dr. Rowe. And thank you to the panel for appearing today. My question is for Dr. Coffey. The suicide prevention approach that you highlight in your testimony centers on achieving ideal health care delivery and 0 incidents of suicide, rates of perfection that I'm sure many would say are impossible, particularly in a healthcare system as large and complex as VA. In what ways does your approach to preventing suicide differ from the suicide prevention approach occurring in VA right now? And why do you think your approach is not only possible, but preferable for our nation's veterans?
Well, I can't answer the question about what's happening in the VA right now because I don't know. I'm not privy to the detail of those operations. As I said earlier, I firmly believe that everyone that works in the VA is committed to eliminating suicide. I have no question about that. Stepping back, in general in healthcare, we have the same story. Hardworking people, smart people, dedicated to doing the right thing, but what's getting in the way is terrible, broken systems. And that's the general issue. That was the issue that was called out 20 years ago in the Chasm report. And I'm sad to say that I don't think we're a whole lot further along today in fixing some of those fundamental systems issues. So I think that's the starting point. We have to step back, look at these systems, and begin to think about, okay, what adds value and what doesn't. And if I may just tag on a question that came earlier, which was a wonderful question, and it was, what could this committee do to help the VA? And I thought that was fabulous. And I get goosebumps thinking about it. My boss at Henry Ford asked me the same thing when we started our work and when we didn't get the grant. And I had to beg for some time. I went back and thought about it, then I went back to her and said, help us with the bureaucracy. Let me bring to you a list of issues that we don't think are adding value. We could be wrong, and we may not understand it completely based on your perspective, but let us bring you a list. And if you agree, can we take some of these off the plate? Can we stop doing things that, in our view, at the front line, don't add value to the care of the patient? That was a blessing from heaven. She stood by that, allowed us to make those changes, and perhaps there's some opportunity there for the VA. I've worked in the VA, and I know the challenges of bureaucracy in such a system. And it's all well-intentioned. It's there to try to make things better. But maybe it's a time to look at some of that and say, okay, this has outlived its usefulness. Let's let it sunset and move on to processes that add more value.
Thank you, Mr. Chairman. I yield back. And thank you.
Thank you, Ms. Radewagen. Ms. Brownlee, you're recognized.
Thank you, Mr. Chairman. I wanted to ask, with the way VHA is set up and organized, the medical centers have a lot of autonomy. And when we're talking about this grave issue of suicide and solving that, and you're talking about a lot of different programs, different directives, expectations, and the like. We know from OIG reports that we have different medical facilities who may be out of compliance and not fulfilling all of those requests and requirements. So, when an organization as big as VHA is, who has the accountability? How do you ensure that each one of those medical facilities are in compliance and who are doing what you're asking them to do? They even have large controls over their budgets. So how are you ensuring that they're investing in their facilities to meet some of these goals that we're trying to attain and reach by actually really reducing the suicide rate?
Thank you for that question. One of the ways that we do that, obviously, you are right. Each individual medical center operates on its own. We have the network directors, and the VISN directors are really responsible for ensuring that we reduce the variation and that we then make sure that facilities across that entire network are complying with what they need to do in each of these areas. We have a lot of conference calls. We have a lot of information that's shared. We have a mental health lead, for example, in each network who will visit each of the medical centers and make sure that the things that are happening there are consistent with what the policy is across VHA. We also have things at the national level, and Dr. Carroll's office in mental health also looks at the consistency of what we're doing across the country.
I don't want to... the next question I have is in direct opposition to Dr. Coffey's philosophy in terms of a new approach to all of this. But what are the consequences for a medical center that's not putting their resources where we want them to put them in relationship to suicide prevention?
One of the things that I really believe is that each everybody, that the idea of zero suicides and that preventing suicide is the VA's #1 priority, I believe, is shared by every executive across our country. So I think the issues are less with not doing it, but how is it they prioritize some of those things? And so that's what the job of the network and the mental health office is, that we need to make sure they prioritize that. The consequences, the way I would look at it is accountability is all about making sure that you have the best outcomes for your patients. And that if that doesn't happen, that is something that we will be discussing in our evaluation process.
Well, with suicide, we haven't moved the dial. We're not getting good outcomes. So it's, and I mean, I think that's why we're having this hearing and why there's such a, such a focus on this. And it just seems to me that the system, the way it's built right now, is not working the way we would like it to. It may be in general patient care, general mental health care, and the like, but with regards to suicide, it's still, we're still dealing with the issue. So I don't have that much more time, and I wanted to ask another question. And I don't think that we can really solve this problem without knowing, understanding where the problems lie. And I think we have, over the last couple of years, we have really started to break down, of the 21 suicides per day, who are those people, and what are the demographics? And so I know in the staff report we're saying, of that number, it's about 16.8 are veterans, and 6.3 of those have used the VHA facilities. But do we know of that population, how many are who are women, who are Native veterans? I just visited the Dakotas the last couple of days, and suicide in tribal lands is disproportional to the rest of the country. So do we know who they are? Because I believe that we probably, well, with Native veterans, we're not getting the programs that the VA has that are good programs to the tribal lands, one, but I do believe that there are different ways to address suicide depending on who the population is. And I've run out of time, so if...
We have the...
Witness will answer the question, yeah.
No, go ahead.
Thank you, ma'am. I'll try and do this briefly. The Together with Veterans program that I mentioned a moment ago will address tribal veterans, and I think that's one of the focus of that programs. In terms of women veterans, we have the programs that you know and that you are supporting us on. One of the things that we saw in our data report between 2016 and 2017, there was no increase among suicide deaths for women who were engaged in VA care, and that unfortunately there was no decrease. But I think that was a point that caught our attention, and so I think we feel that we may be taking steps in the right direction for women veterans in our care. We need to see that number, of course, decrease. And in terms of the question that you asked about other veterans, we know, for example, that of those 11 who die by suicide every day, who have not been in recent VA care, at least 2 of them have been previously, and we are putting together a program to help them re-engage in VA care. We're also looking at what we can do more broadly in the population through our Mayor's and Governor's Challenge. I'm happy to talk more about it with you. Thank you.
Thank you. Yield back, and thanks for the extra time, Mr. Chairman.
You're welcome, Ms. Brownlee. Mr. Bergman, you're recognized. General Bergman.
Thank you, Mr. Chairman, and I'll just get to the point right away. There's nothing more radical than a Marine in the fight, okay? And I thank you, Dr. Coffey, for giving radical a positive definition, because sometimes when we hear terms that it'll pop up either a negative or positive. Normally, when you think of the term radical, it tends to have a negative connotation on the front end, but I applaud you, because if there's one phrase that we have, and is that we never leave a Marine behind, whether it be on the battlefield or here back in the States in their personal environment, because we're looking out for them and making every effort to look out for them at all times. This is a question to the panel. The Improved Well-Being for Veterans Act is legislation that I introduced to help the VA reach out into the community and provide life-saving services to veterans who don't always make it to the VA or are just not within the VA system. As originally written, a merit of this legislation was that we would not only touch the veterans we were not previously reaching, but we would learn from them and use metrics and information gathered, sharing to help the VA and other communities understand the many complex factors that lead to suicidal ideations. In your view, what is the value of reaching veterans in our communities who don't use the VA often or at all, or maybe were in it and are out of it, as you just referenced, Doctor? Would you agree that the learning that we get from these veterans interactions would assist the VA to improve the environment of care and therefore the results on its own campuses and VA facilities? Anybody want to make a comment on that?
Thank you, sir, for the question and for the opportunity to talk about that. We believe that we do need to know about veterans in the community. Our commitment in VA healthcare and certainly in mental health and suicide prevention in particular is to serve all of American veterans. We don't, that is our mission. That is our commitment. It's absolute. And so we need to understand there may be veterans who choose not to receive care or services from VA, and we respect that. But we want to make sure that they are well connected in their community, and we've seen models for.
So it's okay to have other entities that maybe are not employees of the VA to actually make those connections.
We partner with external organizations all the time. Yes.
Anybody else?
So I would just add, from the oversight perspective, we are typically focused on the 6 veterans that are engaged in care and measuring and monitoring the quality of care they receive. But we do support outreach efforts and are targeting products that will hopefully be able to support VA in their expansion of vet centers, which I think, and we as an organization think, will be critical in serving those veterans who haven't, for whatever reason, chosen not to engage in facility care.
Basically, the overall goal is to engage those veterans who are not engaging with the VA. In some cases, you're going to be able to bring them in, because that's going to be the right answer for them. In other cases, they're going to be outliers, if you will, through telehealth or whatever it happens to be. But the goal is 100% outreach. And whatever we do to get that is the VA, it's the right answer, because the VA is the valuable partner. You're the big dog here. You're the St. Bernard, if you will, in this, that is, in the end, going to have the overall responsibility. Dr. Carroll and Dr. Coffey. Dr. Coffey, you talked about the Henry Ford effort. Dr. Carroll, you talked about the Colorado effort. And what I don't know is the time frame of those efforts, but has there been any, if you will, after-action collaborative exchange of data and or results or lessons learned between those 2 efforts?
Not that I've been involved in.
Not those 2 efforts specifically. I think we respect and appreciate so much Dr. Coffey's work, and in our suicide prevention strategy that was published last year, we have tried to incorporate there are 7 principles in Dr. Coffey's work to incorporate those. But the Together with Veterans program is relatively new, and so we haven't been able to crosswalk it yet.
Okay. Well, again, I see my time is almost up, but the point is, when we look at military operations, we talk about intelligence sharing. That comes across all spectrums, and think of you 2 as entities, all of you as different entities, whatever that might mean, to share that intelligence, to share that data collected, because sometimes the best example of something being done, we don't see it. And I'll just conclude by, I know I'm over time. Dr. Coffey, you said stop doing things that don't add value. Okay, Jim Collins, Good to Great, 101. Stop doing the things that no longer add value to your business model. So I enjoin VA, like any other entity, do everything you can to stop doing the things that don't add value. Identifying, break a few china bowls, if you will, in the process, because there are rice bowls that people love to protect. But it's about the veteran and it's about the outcome. Mr. Chairman, I yield back.
Thank you, General. Mr. Cisneros, you are recognized.
Thank you, Mr. Chairman, and thank you all for being here today. Ms. Oshinsky, on May 29th last year, I led a bipartisan letter with my HVAC colleagues, Rep. Banks and Rep. Bergman, requesting the VA elaborate on DOD and VA's responsibilities for carrying out a warm handover of service members from DOD to VA care. As you're well aware, the time period after separation from service is a critical period for service members, especially as it relates to their risk for wellness. This is exactly why I founded the Military Transition Assistance Pathway Caucus with Rep. Bergman to build a bipartisan coalition of members engaged with VSOs, veterans, service members, and stakeholders to solve and improve. Although I appreciate the VA's response to our letter highlighting the President's executive order on veteran suicide, however, did not elaborate in detail what is being done for a warm handover. So I ask you today, what exactly is the VA doing specifically to this critical period between when a service member leaves this active duty and transfers to the VA to make sure that those that are suffering from maybe suicidal tendencies while they are on active duty get the VA care that they need and it's done quickly?
Thank you. One of the things that we have done, we mentioned a little earlier, but I think it's certainly worth continuing to talk about, is the new Solid Start initiative, where we are contacting every service member as they leave the VA, as they leave the service, that they are contacted 3 times during the year that they return to civilian life. Each of those, it's really meant to be, as you said, a warm handoff. Let's find out what's going on in your life. If there are issues, let us connect you. But again, to make sure that they understand that VA, and that's all of VA, is there to support them. They would also be able to refer them to community resources. Dr. Carroll, would you like to add anything to that?
I would highlight 2 other things. One, for certainly the most critically ill people, we often will do a warm handoff between DOD and VA to our trauma centers, our TBI centers. In addition, there's a program called In Transition that will hand off individuals who are receiving mental health care within DOD directly either to VA or set up a community care appointment for them, but to make sure that those individuals don't fall through the cracks.
Right. Well, there's also situations where service members don't want to self-report that they're having any problems, because it may take them out of status, whether it be flying or anything else while on active duty. What is the VA doing to help identify those individuals, to give them a comfortable place so they can report, self-report when they come to the VA after they leave active duty?
Yeah. I think I would highlight our Vet Center program as a particular resource for those individuals. It has a completely separate record system, and it in those at vet centers, many of the counselors are veterans themselves. They really have an expertise in dealing with combat veterans, and many individuals like the situation you described find that a welcoming and good place to go. And we work closely with our vet center partners in the healthcare.
All right. So I would ask, as members of Congress and members of this committee, how can we help you out to make sure that, you have the ability to go out and contact these veterans? Because most veterans aren't going to the VA once they leave, or I should say, once they leave active duty, aren't going to the VA initially. So how do we create that and make it more welcoming for them so that they can do this? And how can we help in that process?
Sure. We appreciate your support. We appreciate opportunities like this hearing and other opportunities to talk about that. We talked earlier about support for our education, training, and research programs. That helps us. And I think to the point of ensuring using all of the platforms that you have, to inform veterans that VA is there for them. We are committed to do that, and if they contact us, we're going to find help either in our system or in their community. We need to change together the conversation in America that there is always hope. There is always a way forward for someone, that no one is ever alone. To Dr. Coffey's point, zero is the right answer, and we're committed to that, and we need to infuse that not only within our healthcare system, but within the population of veterans that we serve.
All right, well, thank you for your answers today, and, use this as a resource and how we can help, because we need to, this is an issue that we all need to solve and we need to work on so that we can get to zero and make sure that these veterans are taken care of. So with that, I yield back.
Thank you, Mr. Cisneros. Mr. Banks, you are recognized.
Thank you, Mr. Chairman, and thanks to each of you for being here today to talk about a very important subject. It's safe to say that the suicide prevention coordinators are the face of the VA's efforts to combat veteran suicide. Yet this committee has found that many SPCs report being overworked and unable to keep up with many of their responsibilities. Late last year, President Trump signed into law a piece of legislation that this committee supported that required the GAO to review the training, workload, and staffing at the VA to ensure that our SPCs have the tools and resources they need to assist veterans in crisis. And I look forward to reviewing those findings in the coming year. Dr. Kroviak, in your testimony regarding the incident at the Minneapolis VA, you stated that the, quote, suicide prevention coordinator did not collaborate with the inpatient interdisciplinary treatment team during the admission, end quote. Is it possible that the SPC at Minneapolis was too overworked to have a thorough collaboration with the treatment team?
So it's certainly possible that that is the case and not just unique to that facility. And I would also add that suicide prevention coordinators are important team members in serving as the face of suicide prevention, but we can't disregard the other providers and support staff that are also critical in combating suicide.
Okay, that's fair, and I appreciate that feedback, but are there any enforcement mechanisms that exist to ensure that staff are informing the SPCs?
So there are policies in place that guide these coordinators, but I would have to defer to VA in terms of holding up those policies and recognizing accountability in those situations.
We don't want to minimize the efforts of the SPCs.
Oh, not at all. And we cite many or in the reports that we found shortcomings, we are very careful to assign accountability to those, as well as those that supervise and run the facility. So certainly not belittling their role, but recognizing it is part of an important team.
Before you defer to Dr. Campbell, I mean, do SPCs have any responsibility to double check and make sure that nothing is overlooked? I mean, what are some of the rules that are governed of how the SPCs operate within the team structure?
Yeah, the SPCs are an important part of our healthcare situation, but as Dr. Kroviak said, we do not place the entire responsibility for suicide prevention on these 450 individuals. It has to be a team effort. They are the leader around suicide prevention, and so they have the responsibility to communicate with the team, and the team has the responsibility to communicate with them, and it is a team-based, that is one of the strengths of our organization, is our team-based structure, both within primary care and mental health.
I get it, and I don't want to walk away thinking that either of you are minimizing the SPC. So what responsibilities do they have? What responsibilities exist within the team structure to keep them informed, to ensure that they are doing their job?
Yeah. One of the key responsibilities that the SPC has, and they have many, but I'll highlight this one because I think it's relevant, is to ensure that any veteran who has a high-risk flag for suicide on their electronic health record, to make sure that flag gets reviewed every 90 days. And I think that's a critical responsibility. That helps us keep track of individuals who are at highest risk perhaps among our population. That is a function that they have. They need to make sure that staff training takes place. They do have this outreach responsibility that we talked about as well to interact across the system.
want to stay on the same subject. I see heads nodding, so I wonder if there are others on the panel that want to weigh in about how the SPCs can, what responsibilities the team has to informing the SPCs. Anybody else?
So my nod was not specific to that, but I would also want to recognize the SPCs play a role in management at a later time in the management of the patient. So recognizing the care that's required up until the point where they would
Thank you.
intervene.
I've got 30 seconds left, so at the end of...
I just would like to also, and Dr. Carroll talked about the outreach. So they do have internal things that they're doing, but we've been talking about rural healthcare. The SPCs, and I'm going to speak particularly to General Bergman's area. I've been up there visiting those folks. They are out there across the Upper Peninsula. And so I think we can't minimize the fact they are part of our public health outreach. That is part of their job. And I think that is going to become more important as we move to this multi-pronged approach to try and look at how do we get our word out to those 14 who are not seen in the VA. It is through those SPCs.
Thank you. My time's expired.
Thanks. Mr. Levin, you're recognized.
Thank you, Mr. Chairman. Appreciate you holding this hearing on this critically important issue to all of us. I have the honor of serving as the chair of the Subcommittee on Economic Opportunity, so I want to focus my questions on that intersection. Assistant Undersecretary Oshinsky, in your written testimony, you emphasize the importance of social determinants of health, which, as you note, include economic factors such as employment and housing. The CDC includes strengthening economic support as one of its 7 core strategies for suicide prevention. But as far as I can tell, none of the goals or objectives in VA's national strategy for preventing veteran suicide address economic opportunity specifically. I'm concerned that perhaps we're being too siloed within VHA. So I wanted to ask how you can work better together. Specifically, how can you connect veterans at VHA with the VBA provided benefits, such as the GI Bill, vocational training, home loans, and housing vouchers? So in general, could you address how is VHA going to better collaborate with VBA on suicide prevention?
Thank you for that opportunity. I think, again, that solid start is the first place that we're looking at, because VBA is really a key driver in making this happen, and they are going to be ensuring that we connect people right away when they begin to leave the service and enter civilian life. So I think that's certainly one item. We do understand that the economic factors in a veteran's life can be a big determinant of what happens and their mental health status. So we obviously cannot ignore that, and I think we are looking at making sure that veterans have housing. We do get involved in helping them with job placements. So, Dr. Carroll, would you like to elaborate on some of those?
If I could mention 2 things, sir. I think within our mental health programs, our compensated work therapy program and supported employment, we want to help veterans, particularly those with mental health challenges, find and sustain, competitive employment in the community. And VA is working with, through our Office of Strategic Partnership, through our office working with the Chamber of Commerce, also looking at what we can do to support employers to hire veterans and to recognize and support veterans within their workforce. So we're looking beyond just working within our own organization. Certainly our partnership with VBA is important, but what we can do with the larger community.
Thank you. If there's anything that we can do on the policy level to help you better collaborate, we'd obviously like to entertain that. Dr. Kroviak and Dr. Coffey, VHA has set forth several policies to identify and mitigate suicide risk, but multiple OIG reports have found that those policies aren't being consistently followed. So what can VHA leadership do differently to promote policy compliance among facility staff?
So much of our recommendations are focused on filling leadership vacancies and other staff vacancies to promote consistent training and consistent carrying out of those policies. We've also talked about culture, to where we have identified in several high-profile reports to where staff members will complain, will speak up, will say this isn't right, this has been consistently not practiced, but the culture was such that after they complained 5 or 6 times, they stopped because there was no action in place. So really supporting effective leadership, responding to leadership vacancies and staff vacancies. And again, I point to a staffing model, understanding what you need so you can design it to work.
One of the local feedback from local veterans is VA as a whole is doing a good job, but local VA facilities are not being held perhaps to the metrics or accountability that's necessary. So looking at ways to address that, I think, is helpful. Finally, I wanted to turn to VA police officers, who I think are generally doing a great job playing a key role in de-escalating difficult situations on VA campuses. Mr. Jackson, how many of the 400 hours of training that VA police officers receive are specifically focused on suicide prevention?
Yes, sir. 30 and a half hours are definitely focused on suicide prevention, and then 24 hours on doing scenario-based, because we want to evaluate that you are doing the right things in terms of recognizing, de-escalating, and identifying. And as Mr. Shinsky mentioned earlier about the saves that the VA police have done, that's just a few. It's been quite a few.
And, Mr. Chairman, my last question, we've heard a bit about security cameras and the issues there, where in one instance cameras hadn't been operational for 3 years. Who's responsible for maintaining security cameras on VA premises, and what are we doing to fix these issues in the future?
Thank you for the opportunity to mention that. The facilities director is responsible for making sure that the equipment on the site works. I think that it's one of the items that the Office of Security and Law Enforcement reviews during their reviews, whether those be yearly, bi-yearly, or every third year. So they will oversee to make sure that we're doing that, but it should be a facility director responsibility.
Is that something we can do a better job of, though?
Yes, we certainly can, and I think we are working on trying to do that. We have started an initiative to look at make sure that our cameras are operational and that they are able to be viewed.
We'll look forward to following up with you, and I thank the chairman and thank my colleagues on both sides of the aisle. Look forward to working together to continue to address this crisis in our country. Thanks, Mr. Chairman.
Thank you, Mr. Levin. Mr. Watkins, you're recognized.
All right, thank you, Mr. Chairman. Thanks to the panel for being here. This question will be for anybody who would like to respond. The 22 per day is a raw number. Can someone comment on what percent that is? I understand there's somewhere in the neighborhood of 21 million veterans, and how that percent compares to the general population.
Yes, thank you, sir. Happy to talk about that. Actually, the daily number that is typically reported is 20 a day, and that includes about one active duty service member, 2 or so Guard and Reserve, and then 17 individuals who are veterans. Of those, 6 have been engaged in VA healthcare in the year or 2 prior to their death, and the 2 of the 11 have been engaged in healthcare at some point, and the other 9 not engaged with VA. So that's how it breaks down. What we see in terms of the rate in the population, it's about 31 per 100,000. What we have seen between 2005 and 2017 is there was a significant increase in the American population rate of suicide. There were somewhere in the neighborhood of 86 deaths per 100,000 among American adults in 2005, and it went up to 124 in 2017. During that period of time, there was an increase among veterans, the rate, but I do not recall what it was in 2005. As I said, in 2017, it's 31. What happened, though, is that the population of veterans went down. So the veterans are about 1.5 times more likely to die by suicide than individuals in the population.
All right, forgive me. The 100, so just looking at 2017.
Yep.
124 per 100,000 at the national level.
Yes. Americans.
Americans, correct. Yes. 31, but veterans, 31 per 100,000.
Correct.
So why is it 1.5 times more likely to kill yourself if you're a veteran? The numbers don't add up.
Because it has to do with the size of the population.
But we're
We'd be
taking
happy
the
to
size by taking the denominator, 100,000.
Yeah.
Right. That you are giving.
Let me
a
get our
percentage.
data experts to review the statistics with you, sir, but.
Yeah, because it looks to me like it's 3 times more likely if you're a citizen as opposed to a veteran. That's
okay.
Okay. 31 veterans out of 100,000 veterans kill
Yeah,
themselves.
in 2000
124 citizens out of 100,000 citizens. There is a denominator, so there is a percent there.
Right.
So
the reality is in 2017, 6,139 veterans died by suicide, and that's the number that we need to get to 0 per Dr. Coffey.
Sure.
And we agree with that, right?
I understand.
We'd be happy to sit down and walk through our whole data report if that would be helpful.
Sure. I want to make sure that I know what I'm talking about when I go and look at percentages.
Yes.
Because what you just cited me is that it's roughly 3 times more likely to kill yourself if you're a citizen. That's literally what you just cited. Maybe somebody can pull me aside after this, but 31 out of 100,000.
I will have to go
veterans.
back, and I may have misspoke, sir. So
Okay.
I will own that. I will go back and look at that, but let me.
All right.
Yeah, you're right. That doesn't make sense.
And the reason is because as a veteran and as somebody who's buried friends, I've got people approaching me and saying, hey, walk me through this 22 per day. And so I'm turning to you and asking you to walk me through it. So because I'm hearing pushback, and what you just said is consistent with the pushback. So you don't need to scramble to find the answer for me right now. It's just
I apologize to you and the committee if I misspoke on that,
That's okay.
sir. We're going to happy to get that
Well,
right.
politicians never misspeak.
well.
No, don't worry about it. We'll
right.
get to the bottom of
All
the
right.
numbers. I just eventually want to know what I'm talking
We
about.
want to make sure you have that information, and we appreciate your support.
Of course. Ms. Oshinsky, the death of a patient in a VA facility is a never event, which means exactly what you would think it should never happen. But when it does, what sort of internal review of the systems and the procedures take place?
Thank you. We have a root cause analysis that takes place, which looks at exactly what happened and what are the reasons behind that, and what are the things that need to be done to correct it. So that's kind of from the investigation side. If we think there is something more that needs to be done, an administrative board of investigation may be chartered. It depends on what we find as we're looking at the situation, as we collect the facts. However, I think one of the other important things to talk about is the work that we do when this happens with the staff or with veterans who may have interacted with those individuals. One of the things you find is veterans participate in these groups, and when we have one veteran who may lose his life, it affects greatly those individuals who interact with that veteran. So we work also on inventions with the staff as well as veterans who work together with that individual.
Thanks. I'm out of time. I yield.
Thank you, Mr. Watkins. Ms. Underwood, you're recognized.
Thank you, Mr. Chairman. As a public health nurse, I know just how important it is to advance solutions to the veteran suicide crisis that are data-driven and that are evidence-based. Identifying strengths and weaknesses in VA care allows us to focus on those areas that require the most immediate attention. And one of those areas is mental health and suicide prevention workforce. I understand that vacancy rates among mental health clinical staff are critical challenges facing many of our communities, including some at VA facilities. So at the outset, I will say that I know that just in the community-based setting, this is a problem, okay? What actions, Ms. Oshinsky, is VA taking to retain staff and fill vacancies in the mental health and suicide prevention space?
Thank you for that question. One of the things that we try to do, again, is make sure that people are very well oriented so that they understand exactly how they are going to interact in that situation.
Oh, yes, ma'am. I'm sorry. We have a limited time. So just honestly, what are you doing to fill the vacancies, if you can?
What are we doing to fill vacancies? We have open and continuous hiring so that we never close a vacancy. We continually put that out there so that anytime anybody wants to apply for a job, they have that opportunity. It doesn't mean that a vacancy has to exist, so that we would constantly have people able to step in, that they would already be qualified and we could hire them, overhire them. And that's something that we do on a routine basis when we can do it. Unfortunately, as you know, often there's a gap. And we don't have those. But open and continuous is certainly one of the things that we've done to improve hiring.
Okay, thank you. Another area is lethal means training. Research backs up the life-saving benefits of creating additional space and barriers between a veteran who may be experiencing suicidal thoughts or ideations and the lethal means for them to complete any suicidal action. It's my understanding that VA has implemented lethal means training for all VA mental health care clinicians who interact directly with veterans. Dr. Carroll, is that correct? And can you confirm exactly which categories of VA staff are currently receiving the lethal means safety training?
I will have to get back to you about which categories of employees across the board, but yes, all mental health providers would be required to receive that training.
Okay, and in that response, can you please outline like clinical and if there is any non-clinical staff that are receiving that training, and whether it's voluntarily offered or a requirement?
Yes.
And sort of some of the details around that training would be very helpful. Can you also tell us more about the training that the VA has developed? Like how often do staff have to receive it, things like that?
Yeah, the lethal means training is not currently an annual requirement, but I think the frequency of training we will get back in our response to you.
Okay.
We've also developed a lethal means training that's available widely in the community in partnership with the American Foundation for Suicide Prevention, as well as the National Shooting Sports Foundation.
And then to develop that training, was that something internal to VA, or did you work with outside experts?
We worked with outside experts.
Was it just the Sports Foundation or other?
And the American Foundation for Suicide Prevention.
Okay. And then what's your understanding of the lethal means safety training that contractors receive? And would you say that it's equivalent to what the staff receives?
Well, I would like to take that for the record so we
Okay.
make sure we get you the correct information.
Thank you. In some instances, some of the veterans in crisis no longer require inpatient care or supervision by the medical staff at the VHA centers. This requires a handoff to another responsible party. It might be the veteran's family or other members of that veteran's support network. So Dr. Carroll, what resources are available to families and the support networks for the veterans that are at risk of suicide? And are they able to coordinate with the veterans' clinicians? Are they able to access trainings or any other educational resources provided by the VA?
Yeah, certainly family members are part of the team that cares for veterans, and we respect veterans' wishes in terms of having family members engaged in their care, but to the extent that they are supportive of that, we welcome them into the care process. We also have resources available to family members just like they are available to veterans, such as the Veterans Crisis Line. We also have a program called Coaching into Care, which is a specific resource for families to call, in particular if their veteran may be hesitant or reluctant. It will help the family kind of understand what some of the resources are and how they can maybe help that person towards getting into care.
Well, I appreciate that, but that's on the front end. I'm talking about after someone's already received care at the VA, they've completed an inpatient stay, and they need to be discharged. There needs to be some kind of handoff.
Yes.
And to likely a community provider. What we're seeking to understand is the type of coordination that's offered in that handoff and information that's being shared to both family and other clinicians in the community or support networks, of which there are plenty in many communities around our country. So can you speak a little bit about that? I know I'm out of time, so maybe you can take that for the record if the chairman would allow him to answer. Okay, if you would answer.
Yeah, so families, there should be a warm handoff when someone leaves a inpatient unit to make sure that they have an appointment, for follow-up, and they understand. And in many cases, the provider, if it's within our facility, may come onto the unit and may see that patient already, or have an existing relationship, and the family member should be involved. If they're going to the community, that community provider needs to acknowledge that they have an appointment, and then we would need to follow up to make sure that handoff actually occurred.
Okay, so then for the record, then we'll probably submit a question, because I think I heard you say that community clinician is allowed in before that handoff occurs to the VA facilities. Just want to really drill down on that, along with the other questions that we had. Thank you so much to our witnesses for being here. Appreciate it. Thank you, Mr. Chairman.
Thank you, Ms. Underwood. As always, you're very prepared, and I admire your questioning. Mr. Barr, you're recognized.
Thank you, Mr. Chairman, and I appreciate you holding this hearing on this very important topic. I appreciate all of our witnesses for your work on preventing veteran suicide, which is just an absolute tragedy in our country. And as we all agree, it's essential that the VA take every step possible to identify and address suicidal risk factors for veterans, especially in the care of the VA. Before getting to my questioning, Mr. Chairman, I do want to raise a concern. On December 12th of last year, I sent a letter to you requesting a field hearing in Lexington in our district on the topic of equine-assisted therapy, a topic that you know I've been passionate about and advocating for Congress since, and this has received bipartisan support in this committee. Since then, though, my office has not received a response on this, and our office was told last Friday to be expecting a call from your staff regarding the request, and despite multiple emails and calls, we have not received an answer. Ranking Member Rowe has replied in support of the hearing, but we are awaiting your support. At the VA Medical Center in our district, the veterans using equine therapy at the VA are in the Mental Health Resident Rehabilitation Treatment Program, and I know, Mr. Chairman, you have equine-assisted therapy facilities in your own district that serve veterans. I do think a field hearing on this therapy is in line with our suicide prevention goals in this committee, and I would just ask, Mr. Chairman, and I'll yield to you, can we get a commitment that we'll get an answer on that?
So, Mr. Barr, field hearings in terms of our committee travel budget and our staffing have been restricted to chairman of committees and the ranking member. So we usually have a reciprocal agreement among chairman and the ranking member on topics they want to choose. I'm going to have to adhere to that tradition and precedent. However, so I cannot support a field hearing, but I am interested in equine therapy, and I'll look at my schedule, and I'll look at, short of a field hearing, I can perhaps work with you on a visit.
Well, I know you are, Mr. Chairman. I appreciate that, and I know Chairwoman Brownlee is as well, and I appreciate both of you all expressing interest in working with me on that, whether we have a field hearing or not. Ms. Oshinsky, I would like to welcome you and your colleagues this morning, and again, thank you for your work to counter veteran suicide. I'm heartened to hear that since 2017, all VHA employees are getting training, both clinical and non-clinical, mandatory annual suicide prevention training. I think it's important that we are giving veterans every opportunity to talk about suicidal ideations and get the help that they need. I have heard, however, from veterans in my district that veterans are more hesitant to talk to staff at the VA because of a lack of shared experience if those staff are not veterans themselves. And so my question is, would you or any of your colleagues see a benefit of a peer support program enfolded within the VA where veterans can process their experiences with other veterans?
Thank you for that question. About a third of our employees currently are veterans, so I think there is some possibility there, but we certainly recognize and are beginning to incorporate more and more peers within our treatment areas. I think in particular in mental health, we've made a huge effort there, as well as in that whole health initiative where we have peer-led groups for people, for folks who come and are veterans who want to participate in some of those areas. Dr. Carroll, would you like to expound on what we're doing with peers in mental health?
Within mental health, we have over 1,100 peer support specialists. These are veterans with the lived experience of mental health experience themselves, as well as being certified, and we are also incorporating them into our primary care.
Well, that's great, and the more the better of that.
Yeah.
That's the feedback from folks in the 6th District Veterans Coalition, veterans that I serve. Dr. Kroviak, kind of an overview as the Inspector General's office. Overview, I read about this terrible tragedy at West Palm Beach. Are we getting better overall, or are we getting worse? What's the trend line?
So oversight gives you an incredible perspective in terms of how care is being delivered and the consistency with which policies are being carried out. I think what our work highlights, as it did in West Palm, is that there are consistency issues with staff carrying out relatively understandable policies and procedures, and we fault much of that or hold accountable leadership in those situations, the multiple layers, the service line managers, the facility directors up through the VISN. So looking at leadership vacancies, instability of leadership and other staff vacancies, it's ripe for issues like we report on.
Well, my time has expired, but Ms. Oshinsky, I did want to just commend my friend, Mr. Levin from California, bringing up the VBA and interaction. Some of my veterans who are in difficult situations, their frustrations and their vulnerabilities are compounded by the difficulties that they have with their interactions with the VBA. So I think we need to watch those veterans, particularly that are having trouble interacting with the VBA. Thank you. Yield back.
Thank you, Mr. Barr. Ms. Lee, you are recognized.
Thank you, Chairman. Thanks for your leadership on this incredibly important topic, and thank you all for being here. As I've sat here and listened to all of your testimony and the questions, Dr. Coffey, I have one question for you. The Henry Ford Health System, how many hospitals, patients did that encompass?
I can't give you the number of patients. It's a very, very large vertically integrated healthcare system in the Midwest. It owns and operates its own HMO, which is sort of the test tube in which we did our measurement for the rates of suicide. But, and that was around 500,000 people. But the system
Half a million people population.
In that membership in the HMO. at one
HMO,
time.
okay.
But the system serves many, many more individuals who are not members of the HMO. So
Okay, yeah, I just, my question is really around sort of the complexity of the VA and the medical centers. We have 170 medical centers, 1,400 community-based clinics, 9 million, serving 9 million vets. And I certainly love the radical idea of perfect, a goal of perfect care. And I think that's certainly a goal that we should have when we're talking about men and women who have served this country, to make sure we're getting to a point of 0 suicides a day. I certainly believe that that should be the goal. And my question is, as I sit here and listen to all of our members ask questions on oversight, we have the OIG. Clearly, we hear our constituents with their frustrations, whether it's with the VBA, the VHA, et cetera. And my question to you is, when you talk about your roadmap, I imagine you were invited here because we're intrigued by this concept and are hoping that potentially we can implement this concept within the VA, especially as it pertains to suicides. So my question is really, when you think about your roadmap, to me the most important part of it is your just culture and making sure you're asking why and how instead of who.
Yes.
And the question I have to you is based on just the general concept of how the VA is run, how we provide oversight as members of Congress. Do you think that's possible?
Absolutely.
Okay.
Of course it is. Absolutely.
I'm glad to hear that. Now, my next question is, you know, basically we have 6 veterans a day who are in care of the VA who commit suicide. When you talk about a roadmap, and when we talk, I feel like we have, this is such a overwhelming problem for us, because we're not only dealing with the 6 in our care, we're dealing with the 10 that are not in our care. And we're looking at the handoff between the DOD and us, and then those men and women who we failed at the handoff, who are now in the population, who are accounting for that as well. And so I guess my question is, if you were to establish a roadmap, would your recommendation be to focus first on the 6 in our care, and then if we can get to a 75% reduction or 100% reduction, then look at how do we get those 16 into our care?
Sure.
And, you know, I'm just trying to wrap my head around a roadmap, because I sat here today and listened to the suicide prevention strategy, the mental health sustainability initiative, the solid start. I mean, it's just so, I feel like we continue to pile on and on and on initiatives. And yet people who are running these facilities and people who are providing the care, and then the culture of when we ask who and the accountability and what we're doing about that, I just feel like we're on a hamster wheel here. And so if we are in fact going to adopt a a perfect care policy, I'd like to see us look at how we are putting that roadmap into place. And, you know, I'm more of a, what steps do we need to take to get to where we need to be going? And I think that my question, I guess, for Ms. Oshinsky would be, what is it that this body can do to help promote the type of culture that would be needed to implement this type of perfect care scenario?
Thank you. It is a challenge, and I agree with you. We are trying to do very many things. I think what we heard today about supporting the just culture, that this is not about an individual failure. This is about how we need to change and work the system. Because as I said before, I can assure you, in terms of accountability, any provider or any person who has any interaction with a veteran who harms himself is forever remembering what happened. And so I think this committee helping to spread that word that we need to make sure that we have a just culture, and that when we fix things, we are fixing things so it's individuals are not the issue. The issue is, how do we make the system work for the betterment of the most number of veterans that we can? And I think by having this hearing, this is exactly what we need.
Okay. Any recommendations, Dr. Coffey? I'm sorry, I'm over my time.
Well, no, I feel you, and I agree with all that you said about complexity. I can't specifically advise the VA on this matter, but as the general strategy, what I would recommend is, where's the low-hanging fruit, and then where's the biggest opportunity? You know, I tell my team, there are 1,000 things we could do this year. There are 100 things we need to do this year, and there are 3 things we're going to be able to do this year. And our job as leaders is to make sure we've identified the correct 3 things. And so you just go through your priority setting at that point and then go from there. But I do think there's a balance between where's the low-hanging fruit, some quick wins, and then where is the big problem that we can begin to sort of chip away at.
Thank you, Ms. Lee. The just culture, that term, I think, is very important. I want to mention it in light of the fact that we have some issues with the VA's Office of Whistleblower Protection. Making sure whistleblowers are protected is definitely part of making sure that we have a just culture, and it is about the culture. But before we wrap this up, Dr. Rowe, at the urging of Dr. Rowe, and I'll also ask him to ask questions, to ask questions along the line if I don't get it completely answered. But Ms. Oshinsky, to the extent possible, I'm throwing a curveball at you because it's a, but I got to tell you, 213 passengers who were evacuated from Wuhan will have already landed in the heart of my congressional district. And I did appreciate my chat last night. I had a briefing with the Undersecretary at HHS and an individual at the CDC. But here's what I think is of concern for this committee and this jurisdiction. In light of a grave public health concern and I'd say even threat, what plans are the VA, have the VA begun a planning process for taking care of our veterans? And as you know, we have a 4th mission at the VA, which is also disaster preparedness. and operating emergency caches. And so I wanted to know your thinking in terms of what sort of planning is starting to occur already with our primary role of providing health care to veterans. And then we also have a community responsibility through our fourth mission.
Thank you. Actually, as I left for this meeting, I had to leave a planning process for how we are dealing with the coronavirus. But however, I will tell you that we have been monitoring this on open source as well as a collaboration with HHS since the initial reports began from China. So we have been identifying what are the requirements that we need to have in terms of laboratory testing as these cases present themselves. We have widely shared and had a conference call yesterday with chiefs of staff across the networks about how do we proactively deal with what are things that you need to make sure all the providers across your site know. We shared last night making sure that all the modules from the CDC in regards to education and how we train people were distributed to all the medical centers across the country. We are likely going to, as things get closer, we're giving out more information, and that was part of the meeting that I left today. What do we do, as you said, when we have now people who are coming back from that part of the country? Some of them may be providers. Some may be people who are within our system, and we need to make sure that we're giving out the appropriate guidance. So we have, like I said, we are collaborating daily with HHS to find out what's going on and making sure that we are following everything that they are putting out and telling that to our folks. So I think we're being very proactive. I would likely see an incident command being set up if we see a more significant spread.
Well, as you know, we have numerous veterans in the Philippines, American veterans that utilize the foreign medical program. And we also operate a clinic attached to the embassy there. And we also, in the region, of course, have veterans on Guam and the Northern Mariana Islands. So, closer in proximity to, the epicenter of this epidemic. Are your plans also taking account of our exposures there?
Yes, thank you. We are, actually, we've been monitoring the Philippines very closely recently with the volcanic activities on that island, and actually in our morning meeting we have been looking at that situation on a daily basis for the last 2 weeks. So we do continue to have monitoring with them. Again, the difficulty there with the change in time zones, but we have daily interaction with them about where we stand both on the environmental situation there as well as what's happening with the coronavirus.
Dr. Rowe, do you have anything that you want to ask?
And I mentioned this to the chairman during this, that I hope the VA, because we've already had in our local community a shortage of gowns. And that occurred before the coronavirus outbreak. We had to delay some elective surgery because of just sterilized paper gowns, shortage of those already. This reminded me of a couple of things that occurred. It was sort of funny. There was a flight from Hong Kong or somewhere when the bird flu was going on. Maybe it was Ebola. I can't remember which the outbreaks it was, but this guy sitting in the airplane, and he said, well, I think I have this. And so what the airlines did in this highly contagious disease is kept him on the airplane, let all the other vectors go that had been exposed to it, which could have exposed the whole country to this problem. So I think educating the public about this is extremely important. And then being prepared for this if it does. Hopefully, what I always did when I went to the operating room was prepared for the worst disaster I could think of, and a train wreck, and hope I went on a train ride. And I think that's what we need to do in this situation.
Thank you. One of the things we're doing is pulling out the things that we had put in place when the last pandemic flu outbreak came around, and are looking at what we can quickly put into place. Again, we have the procedures and processes from the last time around, and I think can quickly implement the things that we need to do.
This one's a little bit confusing because we don't know how it spread, quite frankly, yet. We don't have rapid turnaround testing. The CDC's got a nice test, but it'll take a couple of days to get the results back. So those are the things we have to beef up. can I just finish my statement, then I'll just turn it over to you.
Go
to
ahead,
close it
sir.
up.
Go ahead.
I think, and Dr. Coffey, I wanted to compliment you once again on broken systems. They are deterrents to providing quality of care, and also what doesn't bring value. I remember as a young doctor, I'd learned how to do laparoscopy when I was in the Army, and I came to Johnson City, Tennessee, and I was ready to do my first laparoscopic exam, and I went in to see this patient before she went in, and she had been shaved from here to her knees. I mean, it wasn't a hair. I said, well, why did we do that? And they said, well, that's the way we've always done it. And I'm afraid in healthcare, that's a lot of what we do because of how we've always done something, and never ask ourselves, does this bring any value? Is this added step? Improve quality of care, outcomes, all that. And we need to step back and look at the whole system. I could not agree with you more on that. And I think the thing also that's disturbed me so much is that suicide is a national tragedy. It's not just the VA. It's a national tragedy for us. We lost, when you hear the number, 50,000 people died of self-inflicted, either by whatever method they chose to utilize to end their life. That's bigger than all but 2 towns in my whole district. I don't have a town but 2 that are that large. And I think about that when I drive through them, about how many people in America that have done this. Prostate cancer, 31,000 people died of it. We spent, billions of dollars trying to cure that. Breast cancer, 42,000, same thing. Colorectal cancer, less than the number of suicides. So it is a national tragedy, and it's going to take, not at the 30,000-foot level where we are, but I think you're going to have to solve this at the individual and the local grassroots level, just like you did, Dr. Coffey, like the VA is trying to do. And I do believe the public health approach, when Dr. Van Dalen and I were in Johnson City, we remembered, you remember the old thing, Smokey Bear, only you can prevent forest fires? We've taught everybody how to call, friends don't let friends drive drunk. I mean, all those things that are catchy. But we need to do that for suicide so that you can look after your neighbor and your friend if they're having problems. That's where we're going to have to really reduce the level. All these things we're doing are good, but it's got to be more organic than that. And I personally am agnostic about where someone gets care. When they are in extremis and in trouble, I just want them to get the best care they can get wherever it may be. And I think you all feel the same way. And there are, and we mentioned facilities. I visited of all the bumbles and stumbles that it had out in Denver. They have a great inpatient facility there for psychiatric patients that really look at how to prevent. And I think what the VA should do is go to those places that have the best practices. Instead of trying to reinvent the wheel, take those best practices to each facility. Here, this is what actually works. Do this. And then hold people accountable, as I think, as many of our colleagues have asked. And then I do applaud the VA for trying to contact, Dr. Carroll, you mentioned this, that's amazing when you try to put a touch on 3 veterans who leave every day. I know when I left the military, I just left the military. There wasn't any touch, there wasn't anything. And I applaud the VA for that, but also I'll mention that patients share some responsibility to reach out to. The VA can't do everything. You have to have patient reach out, and then we have to have rapid access to care that they need. I think that's one of the things that when the patient does reach out, that we don't just blow them off here, call 911, call the suicide hotline and leave them hanging. So I applaud, and I want to thank those, the last person I talked to when I left was a fellow who's painting my house inside when I left, and he said, Doc, I just want to tell you, he said, I really get great care at the VA. I hear that a lot. And through all its misgivings, I hear that a lot. And I want to thank you all for that, for everything you're trying to do, and all the panel members for being here, because I know you're all committed to the same thing we are. I yield back.
Thank you, Dr. Rowe. Ms. Oshinsky, just before I launch into my closing statement, Dr. Rowe reminded me when he said something about the shortage of paper gowns. One of the reasons why there was a decision to evacuate Americans and other nationals in Wuhan was that an understanding that the medical system was highly stressed, and if these individuals did get sick, they would be facing an overwhelmed system. and this overwhelm is part of what I'm concerned about, the ripple effect. Beyond the shortage of these gowns, my understanding is that China produces a huge share of our medicines, and that the production facilities are not far from Wuhan. And the VA, as we know, is a major purchaser, a large purchaser of these medications, and it would be helpful to know whether there's a concern of the VA leadership about our inventory of important medications, in the planning process. If you could get back to the committee with some assessment of where we stand with that.
Yes, Congressman, I will do that.
Thank you. Again, I'd like to thank.
Chair, I just referred to my friend Dr. Google, and said the FDA estimates that 13% of the world's API production facilities are in China compared to 28% in the United States, so it's a huge percentage.
It is a huge percentage. Yeah. I'd like to thank the witnesses for their appearances today and their testimony. The crisis of veteran suicide is not new, but our solutions must be. And that's why I introduced the Veterans Acute Crisis Care for Emergent Suicide Symptoms Act, or Veterans Access Act, that will mandate VA cover the cost of emergency mental health care for all veterans, regardless of their eligibility for VA health care or level of service connection. No veteran experiencing a mental health crisis should be deterred from seeking critical treatment because they fear a medical bill. By removing this significant barrier to care, my hope is that veterans can now focus on getting the help they need. I look forward to working with all of my colleagues, VSOs and VA, to make this hope a reality for our veterans. All members will have 5 legislative days to revise and extend their remarks and include extraneous material. Again, I thank you for appearing before us today, and this hearing is now adjourned.
Read that one, Mark. See the percent. Read that.
70%.